So I was called upon to talk about ventricular arrhythmias, and I think it's a good topic. It's still quite broad. There's a lot to learn, and we only have 30 minutes. So hopefully you can pick up at least some useful tips in about ventricular arrhythmias that you can use in day-to-day practice and as we take care of these patients. Okay, so ventricular arrhythmias and sudden death, it's a broad category of arrhythmias, basically arrhythmias arising from the ventricle, but they present in many different ways. People could be totally asymptomatic. They could have minimal symptoms, sometimes just palpitations. And of course, they can be hemodynamically unstable. People can have pre-syncope, syncope, sudden death, and also survive sudden death if they're resuscitated in time. And this is really factored into how we treat these arrhythmias. So depending on the patient's particular clinical scenario, the same arrhythmia could be life-threatening, or for another patient, it could be benign. The arrhythmias are further classified as based on morphology. You can have non-sustained ventricular tachycardia, which could be monomorphic or polymorphic. You can have sustained ventricular tachycardia, which again could be monomorphic or polymorphic. There's specific subtypes. There's reentrant tachycardias. There's something called a bundle branch reentry tachycardia, which is where reentry occurs within the left and right bundle branches. There's bidirectional VT, there's torsade, and then ventricular flutter and ventricular fibrillation. So this is somewhat basic. Obviously, if you've been in the EP lab and worked there for some time, I think this would be very basic for you, but to understand the pathways, what happens during VT and what could be the relationship with the atrium, I think it's good to discuss that. So in sinus rhythm, of course, the conduction goes down the AV node, down to the ventricles. If the bundles are intact, it would go down each bundle. If there's a block in one of the bundles, then it would obviously not go down that bundle, but go down the intact bundle and then come back around over the myocardial fibers to get to the other side. Now, when you have a Wolff-Parkinson-White syndrome or pathway, that means that there's an extra electrical connection, usually conducts retrogradely from the ventricle back to the atrium. And that can set up a reentry circuit where it goes down the AV node and then back up into the atrium and then back around the AV node. And that's called orthodromic reentry. If it goes the other way, where it goes down the accessory pathway down to the ventricles and then back up, that's antidromic reentry. Of course, ventricular tachycardia, a Wolff-Parkinson-White related tachycardia, if it's antidromic reentry tachycardia, you could call that a ventricular tachycardia also, because it is involving the ventricle. And the ventricle is not just a bystander there, it is an active participant in the tachycardia. But strictly, we like to use this term for arrhythmias that originate in the ventricle itself. So it could be obviously anywhere in the ventricle, right ventricle, septum, or the free wall, or any other part of the ventricle. And in these tachycardias, now what happens to the atrial response? I think that's important to know. In most cases, the ventricular tachycardia, let's say it's 150 beats a minute in the ventricle, it will try to go back up the AV node to the atrium. And that depends on what is the retrograde conduction property of the AV node. Does it allow retrograde conduction? Not every patient has intact retrograde conduction, and that's okay, that's normal. Then what happens to the atrium? The atrium could accelerate one-to-one with the ventricular tachycardia and keep up with it. Most of the time it Wenckebachs, so the atrial response is less than what the ventricular tachycardia rate is. And that sets up some other interesting things. When the atrium is dissociated from the ventricle, then now you can have capture beats and fusion beats. So capture beats are where now that extraatrial response that is not one-to-one with the ventricle will suddenly go down the AV node and capture the ventricle. So that's called a capture beat. A fusion beat is the same thing, but only when at the same time there's a ventricular event also. And so the supraventricular event and the ventricular event fuse, and then you have a sort of in between QRS. That's called a fusion beat. So these are signs of ventricular tachycardia. When you have an EKG that shows wide complex tachycardia, but in the middle you're having these narrow beats and intermediate beats, that's called capture and fusion. And in those cases, it's most likely to be a ventricular tachycardia. Just a few morphologies. So this would be a non-sustained monomorphic ventricular tachycardia. They are short salvos and they look very similar. And so that's monomorphic. The first thing you should always look at is what does it look like in V1? V1 is usually the most telling of the EKG lead. So remember where V1 sits, it sits over the right intercostal space. Usually that means you're sitting right on top of the right ventricle. So if it's negative in V1, it means it's starting in the right ventricle and going towards the left because it's negative there. Activity is moving away from that area. If it's positive, it means it's coming towards that area. So it usually means it's in the left ventricle. Here's an example of, again, a non-sustained ventricular tachycardia, very rapid, monomorphic. And look at V1, this time it's positive. It has that rabbit ear, right bundle. So that means it's coming from the left side, the left ventricular wall. Now here's an example of monomorphic ventricular tachycardia. So I wanted to make a point about the atrial response. You can see it's perfectly monomorphic. It's negative in V1. And then if you look at you can see the P waves coming through. There's one P wave there, one there, one there, and so on. And this is not a regular response. So the VA response is not one-to-one because this one's missing a P wave. So this is some kind of Wenckebach phenomena, or it could be completely dissociated. So this is another sign that the atrial activity is not driving the ventricle. This is a patient with monomorphic ventricular tachycardia. Now, ventricular flutter is sort of I guess, generic term when it gets very rapid but it still looks kind of monomorphic. You call it flutter. It's still not ventricular fibrillation. Obviously, it goes on a few more minutes, it will be. This is disorganized ventricular fibrillation. Here's another interesting EKG pearl called an Epsilon wave. So patients who have arrhythmogenic right ventricular dysplasia, right ventricular cardiomyopathy, ARVC, they have fatty deposits in the free wall of the right ventricle. So usually over the area where the pulmonary artery or the outflow tract is to the right ventricle, they'll have areas of fatty deposit. And that shows up again in V1 sitting right over that area. You'll have these notchy looking waves called Epsilon waves. And those are areas of slow conduction over the right ventricle. So as far as the epidemiology of sudden death and ventricular arrhythmias is concerned, the patients we most worry about, the ones you see in the EP lab generally are these patients at the bottom. So these are patients who are very sick. They have arrhythmias, post-MI patients. They're cardiac arrest survivors, EF less than 30%. And the incidence in those groups, so if there were 100 of those patients, you might be looking at 5 or 10 of them having these arrhythmias. So there is a higher incidence. But if you look at where does most of the sudden death occur, it occurs in actually relatively normal people because there's more of them. The general population, the incidence of sudden death is very low, but the events are much higher. And this has always been one of those things in EP that we haven't been able to crack the code here. Which patients are the ones at most risk? How do we identify this group? We don't go around screening the whole population for risk of sudden death. But that's where most of the events occur. All the research studies are done, MEDIT1, MEDIT2, SCUD-HEFT, they all focused on this population where the incidence was higher. So we kind of stopped here And we haven't gotten into this area where how do we, if somebody has an obvious EKG abnormality, QT prolongation, hypertrophic cardiomyopathy, etc., you might be able to identify them early. So when sudden death does occur, it occurs most of the time it's ventricular fibrillation, but always remember that bradyarrhythmias are part of the sudden death syndrome also. People have sudden heart block, they can have torsade, they can have primary VT. And this is important to know because when we're advising somebody to have a life vest placed, the life vest is very good for the ventricular fibrillation events, but it does nothing for the bradycardia when somebody has asystole. So keep that in mind if you have a patient, who might be at risk for sudden death, and let's say they're having a coronary intervention and now they're deemed high risk for sudden death, but they have a bundle branch block. So those are the kind of patients you have to be careful that the life vest may not be sufficient. Long QT syndrome, we do see a fair number of these patients, and obviously it's the congenital form gets picked up usually in kids. Either they have syncope or dizziness, abnormal electrocardiogram. These channelopathies always obviously affect the ventricle, but they also affect the atrium. We've had some patients with Brugada syndrome, for example, who have very severe atrial arrhythmias and have required ablations. In this particular case, the patient has a 2-to-1 atrial tachycardia as well, in addition to the long QT syndrome. Okay, and then patients develop torsade. Torsade basically has two components. It has the long QT interval, which is part of the definition of torsade, and then polymorphic VT, which has this twisting of the points characteristic look. This is always on the board exams. They try to figure out if you have a wide complex tachycardia, what are the signs of VT versus SVT. And the rate is usually not a discriminator. Hemodynamic instability is not a discriminator. Patients can have sustained VT for days, even longer sometimes, and be relatively stable. So that has to do with the ejection fraction of the patient. It has to do with the atrial response we talked about earlier. If they have a 1-to-1 atrial response, they might actually do better hemodynamically because the atrial kick then supplies blood to the next ventricular beat. So you have this 1-to-1 response. It's still moving the blood forward in some ways. AV dissociation is definitely a suggestion of ventricular tachycardia. So if you have wide complex tachycardia and you see those P waves, like we showed that EKG earlier where there's dissociation, then most definitely you can say this is VT. Fusion and capture beats, like I explained earlier, those are signs of ventricular arrhythmia. And positive concordance, that's an interesting sign, and you'll see this sometimes when you have a patient come in VT and they have V1 is positive, and all the way through V6, everything is positive. That's called positive concordance. And you don't see that in SVT, you see that in VT. So if you ever see that, you can confidently say this is a ventricular arrhythmia. So this is fairly simple, and I think most of you probably who've been in ablations are able to tell somewhat, how to lateralize and localize the arrhythmia. So we talked about left bundle. If you have a negative in V1 sitting over the right ventricular free wall, that means it's coming from the right ventricle because the activity is going away from there. And opposite for the left ventricle. If the inferior leads are positive, then you're looking at the anterior wall and lateral wall because that means it's going towards the inferior leads. If the inferior leads are negative, it means it's going away from the inferior wall. So it's starting there. And similarly, negative in AVL implies some activity or origin along the lateral wall of the left ventricle. So a few words about mapping techniques, which again, if you've been in ablations, we do all of these during a VT ablation, as many as we can as many criteria we can meet, the better it is. So we do activation mapping, finding the earliest signal. Now remember, finding the earliest signal only works if it's a focal arrhythmia. So if you have some kind of papillary muscle VT, RVot tachycardia, some aortic cusp arrhythmia, that's where finding the earliest signal works. If it's a re-entrant tachycardia, some myocardial scar, then finding the earliest signal is pointless because the circuit, you have to identify the whole circuit, and then you have to find the critical channel where it's going through. We do pace mapping, so we apply the catheter to the spot we think is the source, and we pace, and we see what the QRS looks like. Does it match up with the arrhythmia QRS? We do entrainment mapping. So entrainment mapping is used for re-entry circuits. So when there's a re-entry circuit going on, we place the catheter in an area we think is part of the circuit. We pace. If we get a similar QRS, that's called concealed fusion. If there's a dissimilar QRS, it's called fusion because now you're fusing with the wavefront of the VT. And then we can see the response. What happens after we stop pacing? Is that post-pacing interval equal to the tachycycle length, meaning that we're close to the circuit? Is it longer, which means we are far away from the circuit? And then, of course, 3D mapping has changed everything. Here's a few examples. We have cases where patients develop papillary muscle VT. And of course, this is the VT in the reference box. This is us pacing. We're getting a very good pace map. You can see that it's almost similar. I like to look at AVL usually because I think that even when most of these others will match up, AVL has some subtle findings that help me. So I look at AVL or AVF, try to pick one that has the lowest amplitude, and that helps me figure out if there's any subtle changes still. So this particular case, patient had a papillary muscle VT, and I just drew that out just to show you what you might be dealing with is not just one particular spot, but a whole bundle of muscle. So there's two papillary muscles. There's one that's the anteromedial, the anterolateral, and there's a posteromedial papillary muscle, which is more septal and inferior wall. So the Purkinje fibers, as they come from the AV node, they split into the right bundle and then the left bundle, and then the left anterior fascicle goes to one of these papillaries, and then the other fascicle, the left posterior fascicle, goes to the other papillary muscle. So papillary muscle VTs can, you can also have fascicular VT coming from that fascicle that goes to each papillary muscle. So you can have similar morphologies. The difference being that the fascicular VTs are narrower, the QRS is not as wide. The papillary muscle VTs are wider because they're using myocardial fibers to conduct and not Purkinje fibers. The technical challenges are you could ablate the tip of the papillary muscle, but it might start from the base. And so sometimes you have to do more than just one spot on these papillary muscles. And catheter stability is an issue. Some people have proposed using cryoablation because it sticks once you turn the cryo probe on. You should also use ice or cardosound for these cases so you can identify the catheter relationship to the papillary muscles. So anatomy is critical. You have to know your anatomy on these cases. And we're dealing a lot with these patients who have outflow tract arrhythmia. So this is sort of an REO view, right ventricles in the front, the aorta is in the back. And as you know, we're frequently ablating at the right ventricular outflow tract. And sometimes when we're in the posterior part of the RVOT, we might say, okay, this may be in the aortic cusp. So then we go retrograde transaortic and then come back around and then go to this area. So this is at least we're aware of this a lot more than we used to be. And frequently PVCs will be mapped in the RVOT. If not, then you go to the aortic cusp and map it there. Same in a cross-sectional view, the pulmonary artery is in the front, aortic valve is behind it. So when we're looking at the posterior aspect of that RVOT, now we're talking about mapping the aortic cusp. And in the ventricle, then you'll also see this area called the aortomitral continuity, another place where sometimes PVCs originate from. So a few words about voltage mapping. So we have cases where we can have a perfectly normal endocardial map. There's no voltage disturbance at all. The ventricle even looks normal size. But if you look at the epicardial map, there's a huge scar on the lateral wall. And these are patients typically with non-ischemic cardiomyopathy. There hasn't been, this could be infarction too, but this is the characteristic distribution of a scar in a non-ischemic patient, where they have the base of the lateral wall has the scar. And I don't know if anybody knows the mechanism of that, but patients with non-ischemic cardiomyopathy frequently require epicardial mapping for that reason, because the scar is not endocardial, it's epicardial. Now, when we do the same voltage map anteriorly, you'll get this area where the LAD courses down. And this doesn't look like a infarction distribution. It's more actually a fat pad. So where the LAD courses down to the apex, you'll see this area of what looks like scar, but it actually is a fat pad. And you can imagine that there's going to be more difficulty in applying the energy to this area, because you'd have to penetrate the fat first, and then maybe you'll affect the myocardial surface. So epicardial ablation itself always isn't the answer. You also have to be careful. Obviously, we map the LAD, and in this case, we mark the spot where the LAD is, bifurcates. We mark where the phrenic nerve is, because that's another problem with the epicardial ablation, is you could damage the left phrenic nerve. Typically, during AF ablation, we're worried about the right phrenic nerve. So in this particular case, and you guys have probably seen many of these cases, but this patient had a scar on the septum. We ablate here. We have to be careful about the conduction disease in these patients. Frequently, many of these people already have BIVs. If not, they at least have a dual chamber ICD. And but if you very aggressively ablate here in the septum, you'll end up with complete heart block, and now you have to give them a left ventricular lead. So the techniques have evolved for ablation, going from being very precise to what they call the V52 catheter, where you basically palm the whole scar as much as you can. And I think we're moving back to this strategy, trying to be more precise. The arrhythmia mapping systems have improved a lot. So this is an example of activation mapping. So activation mapping is where we're finding the earliest spot. It's useful for focal PVCs and focal ventricular tachycardia. So we place the ablation catheter until we get as early as possible, the reference being the onset of the QRS. So we'll frequently do this every time we're moving the catheter around. We want to see what is it from, pick a point that you like, and then say, okay, that's the point. I want to go back from there and measure where the sharper signal is. The unipolar electrogram at the site of origin is going to be always negative. Negative because the distribution of the current is away from that spot in every direction. So you place the catheter, the current's going away, and so it's always going to be negative. Once you find that spot, you'll know that it's a negative QS or QS complex, and that implies that you're on the spot. So example of epicardial mapping and ablation, and there's always coronary arteries in the way for some reason. People have debated how far can you be before you can successfully ablate. I think most people agree you have to be at least one catheter tip away. So the catheter tip being 5 millimeters. So you have to be at least 5 millimeters away from the coronary. And the software, the Paso mapping has made life easier. So now instead of visually just saying, okay, this looks good, you can actually get a percentage. They get a reference in the window, and then you pace, and then they lay it over the reference PVC. In this case, you can see it almost perfectly matches the whole. So it's probably a 95% pace match. I think anything above 90 is usually good enough. So this was a case we did recently. Some of you were involved in. Patient had almost a incessant VT Luckily, this patient had a VT that was a hemodynamically tolerated. So the blood pressure was in the 90s. We were able to keep the patient in VT for a few hours, maybe 2 or 3 hours, and then do the mapping. We did a scar map. So this is a voltage map. And after some time, we were able to find that there's this 2 scars on the inferior wall, and then there's a little channel in there. So the new Cardo system has a higher, I think, resolution, and you can see that those 2 scars, there's this little channel in between where there's a slow conduction zone. Slow conduction zones are very important for any re-entrant arrhythmia. You need a slow conduction zone. So for when the current comes back around, it delays and then has time for the rest of the ventricle to recover, and then it goes around and around. So this is a new coherence mapping software in the Cardo system. What it has added is velocity. So velocity means direction and speed. So it has these little arrows that show the direction of the current. And it also has the speed in there. So if there's area of slow conduction, it'll mark those. So if you look here carefully, look at the scar area, you probably see the slow conduction with the arrows moving slower over there versus other places. So we were able to identify the circuit, and after we tried the non-selective ablation where we ablated the whole scar, and it didn't really work because there was a hidden channel in there. Once we found the channel, then the first lesion there terminated the arrhythmia, and he hasn't had any more since for the last week or so. So I'm close on time. That's it. Take any questions you have. Thank you.